Hello, I'm Dr. Marilyn Goski, and I'm a pediatric radiologist at Cincinnati Children's Hospital, and I'm also chair of the Alliance for Radiation Safety and Pediatric Imaging, the sponsors of the Image Gently campaign. What I'd like to talk to you about in the next few minutes is understanding the special needs of children that relate to radiation dose. On the next slide, you can see that what we'll be talking about are factors that impact radiation dose aside from technical parameters that are being discussed quite extensively in this symposium. We're going to talk about alternate imaging that may lower radiation dose. We're going to talk about the variability in children's understanding and their ability to cooperate. And finally, I'm going to provide some suggestions for interacting with parents. Next slide. But before we begin, I think it's very important to take a minute and step back and talk about what an amazing discovery CT is. And in 1972, when I started my radiology residency, there was no CT scanning. The only way that we could see inside of a patient's brain was to do what was called a pneumoencephalogram. A type of gas or air would be put into the spinal canal. The patient would be strapped in and turned upside down in different directions to move the air into the ventricles to get an idea if the ventricles were shifted or missing. And this would give an idea indirectly of the brain. The other way was to do a direct carotid puncture, like my father had for headaches, to do an arteriogram, again to see if the brain had shifted. So we now have the ability with CT to see organs that previously were invisible, such as the brain, the pancreas, the adrenal glands. And I wanted to go back and on this next slide, bring up this point to you. It's said that in the medical literature that from the time an observation is made or a discovery is made to the time it is actually implemented takes 17 years. And I wanted to see if this really held up in the topic of radiation safety. Next slide. And what I found out was actually it's taken longer than that, 31 years. One of the first articles that I could find related to pediatric CT was written in the early 1980s by a pediatric radiologist, and they actually talked about the impact of MAS and image quality, and we're still struggling with that issue. The other article related to pediatric imaging and radiation dose. Next slide. So some of the things that we're going to talk about is the importance of justification, some alternate imaging we could use, how important the variability in body size in terms of technique is important, and the difficulty some children have in understanding the exam they're going to have, their inability to cooperate, and finally talk about parental concerns. In this next slide, we'll start talking about justification, and in the next slide gives us a definition where justification equals appropriateness. Next slide. We know that in this definition from the NCRP, the National Council on Radiation Protection, it describes justification as that part of the decision-making process in which the options that are expected do more good than harm. In other words, the benefits should outweigh the risks. Next slide. But I think what's difficult to think about is that why we care about this. And we know that the rate of medical imaging is increasing. And this is quite an astounding figure, that 10 million diagnostic procedures are being performed every day worldwide. In children, on this next slide, we see patterns of use. 85% of all the imaging that we'll do in a pediatric radiology department is routine radiography, 85%. And only about 11 to 12% of the exams that we do on a daily basis are CT. Next slide. It's estimated that between 6 and 7% are CTs in children, about 7 to 11 million scans a year. But one of the points that I wanted to make on this slide is that 90% of all patients in an emergency room is performed in an adult-focused hospital. And I think that has really serious implications for how the exams are done and the knowledge base that the faculty and the technologists have to be aware of when performing a CT in a child as compared to the frequently performed exams in the adults at their facility. The justification is so important. We can see on this next slide the cover from a conference where the entire conference in 2009 was dedicated to justification. Next slide. One method to decrease radiation dose in CT is not to do the study at all. It's difficult to get a handle, as you can see on this next slide, as how many exams are inappropriate. In the New England Journal Brenner article, it was stated that approximately 40% of imaging exams may be inappropriate. However, it's interesting to note, as they do in the article, that this came from a straw poll, radiologists simply raising their hands at an ALARA conference. And so I think what I take away from this is that we really need more information about how many exams are inappropriate. On this next slide, what I wanted to talk about is how important it is to review every single CT scan. The entire team is really responsible for this. And I think that it is important to empower a CT technologist to be one of the first people to look at screening. Many of our technologists have worked for years in this area, and they really are very familiar with many of the appropriate uses of CT and can then flag it for the radiologists. Another point I wanted to make was this idea of protocoling the exam the night before. It really makes sure that the correct exam is done, and it makes sure that we don't inconvenience parents and families for coming for an exam that we simply cancel once we get there. On the next slide, I wanted to show you an example within the EPIC system of what we use and how we get our information to our technologists. And in this case, one of our fellows is doing the protocoling, and you can see the exam menu over here on the right side of the slide. This next slide shows you the fact that we're really trying to get extensive information from parents, not only about the acute reason why they're there, but also if they have a chronic illness like cystic fibrosis or Crohn's disease. On the next slide, we're going to talk about how we can decrease the number of inappropriate exams. And another method is by informing and communicating with our referring physicians. On the next slide, you can see the heading, the title of an older study that was done in 2004. This was very interesting because what they did is they asked emergency room physicians as well as radiologists whether or not there was potential cancer risk associated with the use of CT. And the results of the study stated that only 9% of emergency room physicians at that time, quite a number of years ago, were aware of the associated CT dose relative to the use of imaging. Another way that we can also find out if there's inappropriate imaging is seen on this next slide. And that is, as part of your practice improvement process, you can audit your practice to look at how individual physicians are ordering CT. And in this slide, you can see that 3A, B, and C are ordering the number of CT scans quite similarly, whereas Dr. D is ordering substantially more CT. Now, this doesn't mean that the studies that Dr. D is ordering is inappropriate. This individual may be a neurosurgeon and need to perform more CTs, but it at least does give you a handle on whether or not there's an outlier, one or two physicians that may be requesting additional CT scans over and above their peers. On the next slide, we see that another very effective method of stopping inappropriate exams is using parents as a source of information. And on the Image Gently website, we have a downloadable parent questionnaire. And this asks for their child's history, how long they've been sick, if they have allergies, and can really act as a double check to providing information for radiologists. There's also the Image Gently medical imaging record card that can also be used as a resource for doing inappropriate exams. If a study was done just 3 months ago at another hospital, it may make more sense to get that study rather than repeating that exam. And this is an example in our EPIC system where our technologists do a wonderful job of actually adding into our documented system what the parents said about why they thought their child's exam was being done. On our next slide, we will talk a little bit about alternative imaging using MRI or limited ultrasound. This next slide highlights the fact that in an older list that I copied from our PAC system, that there was a child with a ventriculoperitoneal shunt, and the child had had 34 imaging studies starting in 2008, of which 25 were CT. Now, the concept of cumulative dose in CT has changed somewhat, and many medical physicists think that that idea of cumulative dose may not be as valid. But so then why should we care about all of these imaging exams? Well, if you think about performing an exam similar to winning the lottery, you can see that if you buy 100 lottery tickets as opposed to one, you do have a greater chance of winning. However, that first lottery ticket and the last lottery ticket have the same chance of you winning. You either win or you don't win with that particular lottery ticket. And that's a simple analogy related to the idea of when you have a incident radiation, that one cell may get a double-strand break and over time possibly progress to cancer. And so this is a really strong reason why we want to continue to try to decrease the number of imaging tests. And so we, on the next slide, can maybe acutely in a child who had significant trauma, we can see that there was a laceration to the kidney, there was perirenal blood, but we don't need to repeat the CT. We can do an ultrasound, and here we see the parenchymal thinning, the distortion and enlargement of the calyces, but it really gives the referring physician plenty of information. On this next slide, we can see that we've really gone from, at least in our institution, from performing small bowel follow-through for Crohn's disease, CT for Crohn's disease, to performing magnetic resonance. And in this case, you can see the bowel wall thickening in the descending colon provides a lot more information if there's a fistula, soft tissue abnormality compared to other techniques. This example you're very familiar with is the idea of replacing CT with ultrasound for looking at the appendix. And the only point that I wanted to make with this is that you really can also evaluate larger patients. Here you can see in 2006 that this is a large patient. You can see the abnormal appendix here, But the point I wanted to make is that abnormal appendix is really right below the anterior abdominal wall, and you would be able to see that appendix. So just because of the patient's size does not mean you cannot start your imaging evaluation with ultrasound. The next slide raises this important consideration. And at our institution, a group of emergency room physicians, radiologists, and surgeons got together and tried to come up with an algorithm that could be used standardized across all patients. And you can see on the left side that in the orange bar, the patients with a high suspicion of appendicitis, the first thing that happens is a surgeon is consulted. In the low suspicion, oftentimes watchful waiting is used with judicious use of imaging. And what we see is in the middle that patients who are equivocal may benefit from medical imaging. But we have a very specific algorithm as to what to follow. Click, you'll see physical exam and watchful waiting are also ways to lower dose. On this next slide, I wanted to also point out that the use of pediatric CT is decreasing in the United States. And this was a large study that came out of Boston Children's Hospital where they looked at over 55,000 exams. And they found out that the use of ultrasound or ultrasound plus CT was increasing, and the use of CT in pediatrics is decreasing since 2007. Let's look at another technique on this next slide that can be used to decrease radiation dose, and that's that idea of using limited MR for hydrocephalus, as you can see here, or as many of you are already doing, angling the gantry on this next slide in patients with VP shunt, doing a limited scan length and lowering dose as well. Let's go on to the next topic on this next slide, and I'm not going to spend a lot of time on this because we've emphasized this point, but this is the relationship of body size to dose. And as Penny Butler, who is a medical physicist with the American College of Radiology, said we really can't measure dose. We can just estimate dose. And I think one of the reasons for this is kind of logical if you look at this next slide. We can see that the two phantoms, the 32 centimeter phantom and the 16 centimeter acrylic phantoms, are large. They're made up of material that is the same throughout. And you can see how different this is than my little patient, who is oval in shape, different organs and different consistencies and densities, attenuation within the body. And for smaller patients, we know that CT scan using CTDI underestimates patient dose. Next slide. Again, we can see that we don't want to use age technique charts. We really prefer to use body width now because we can have a 2-year-old patient, as you can see here, as indicated by the red arrow, who may have the same body width as a 16-year-old. And you might say, how could this be possible? Well, we have patients with dwarfism or chronic disease where they don't grow, and this may happen. So we want to get away, as you can see on this next slide, away from using age to protocol, away from using weight, and to start using body dimension, body thickness or width, or a combination to develop your CT protocols. On the next slide, we're going to talk about a wide variability in children's ability to understand their exam. And if you talk to parents, you will see that the primary thing that parents and children care about is whether it will hurt. And one of the astounding things we found out on this next slide in the psychological literature, that children are really able to understand more than we think, even at a young age. There are theories in child development that can be used to help guide how you approach children of very different ages. So for example, a child who's 2 years old, who really wants to be in control, requires that if you put them on the CT scanner and you ask them to take their socks off and their shoes off, this may set up a tantrum and you can't get the scan done. So by allowing them to say, no, they don't want to do that, you may have success in getting the scan. Children on this next slide have an inability to cooperate. And it's been shown in scientific studies that if you tell them not only what is going to happen, but the sensory side of this, that can be very helpful. So telling them you will feel the table move, but it will not hurt you. Again, this idea of patients being in control, there's been studies that have been done on burn victims that if the child is allowed to take off their own bandage, they actually have less pain. On the next slide, there are very specific phrases that can be used, and you can look at your references at the end to get more information about this. But again, it's the idea of empowering the child to have some command and control over their situation having the CT. These are some, on this next slide, some practical tips that you can use, creating a pleasant environment, identifying yourself, your role in the study, washing your hands, and indicating confidentiality. The last thing that I wanted to mention on this slide, and now on the next slide, is working with parents. And this is one of my favorite quotes, and it uses this analogy of when you're working with both a child and a parent, that you're dancing with two partners. In pediatric radiology, there are really two patients, the child and the parent. And so one of the things that we want to do is make sure that we acknowledge parents' concern. And on this next slide, we want to report, repeat key messages. And our body language, walking in and smiling, identifying ourselves, is really important. Next slide. When the article came out by Pierce et al. In The Lancet talking about potential related to CT scans, we developed in the Image Gently campaign a straightforward letter that we used for parents, targeted at the 6th to 8th grade reading level, and using the analogy of benefit versus risk, and likened it to going to the store and getting a bottle of milk that you needed for your family, which is a benefit with a slight risk of being in an automobile accident. So we can put some of these complex ideas into a context that parents can really understand. So on my last slide, I hope I've provided you with some food for thought that helps you understand why children are so special, the reasons children can't cooperate, and how working with parents can be really very gratifying and helpful to them as well. Thank you for listening.